That's a good question, and you're right, it does differ between countries, which is often suggests that there isn't a right answer. So in the US, people often take 325 milligrams, whereas in Europe now, as you know, 75 milligrams has become a more standard dose. I think it's probably unlikely that one dose is right for everybody. There's a lot of evidence from mechanistic studies, laboratory studies looking at platelet reactivity, that platelet reactivity to aspirin or the response to aspirin varies, for example, with obesity. So there's some evidence that very obese patients have a less consistent response to aspirin. And that seems to be partly because platelet turnover is increased. So with obesity, as with some other risk factors, the rate at which the body makes new platelets is increased. So when you take an aspirin, you knock out the platelets that are around at the time. But if you're producing a lot of new platelets every day, then that might undermine the effectiveness of aspirin. And so certainly obesity is one possible factor that does seem to do that. There are then certain other conditions affecting platelets. So for example, essential thrombocythemia, where people have higher numbers of platelets and higher turnover. And again, there's evidence that in that group, they may need to take either a higher dose of aspirin, but perhaps more practically take a lower dose more frequently. So there are trials of aspirin twice a day versus once a day in those patients with increased platelet turnover. So I think that's one example. And we looked last year at all the trials of low dose and high dose aspirin and looked at the effect of the drug on ischemic events and bleeding in relation to body weight to try and capture these effects. And there did seem to be differences. Aspirin seemed to be more effective at preventing vascular events in people with lower body weight, and low dose aspirin and less effective at higher body weight. Whereas high dose aspirin had the reverse pattern. It seemed to be almost too high a dose at lower body weight, possibly because it inhibits prostacyclin production, but was more effective in higher body weight obese individuals. So I think it's likely there is some impact of body size, although we probably can't yet say what's the right dose for the right person. I think we probably can say that one dose fits all or one frequency of dosing fits all might well be wrong.